Well, November is the month of care for prematurity. And this year, I decided to promote some talks about topics related to a better development of the preterm babies and families. Last week, we had a talk about follow-up of the preterm babies and families. And today, the topic will be related to the beginning of life, the neonatal period. And for this talk, I invited Dr. Arvedson. It is an honor to have you for this talk, Dr. Arvedson. Thank you so much for your time, your precious time. Joan is a very well-known professional, an American speech pathologist who already came to Brazil for a course some time ago and had a lot of papers, articles, and books already published about feeding and swallowing in infancy. So today we are going to talk a little bit about the neonatal period. Some time ago, Dr. Arvedson and I were discussing about NICU and strategies that could improve the development of the preterm babies. And as we already know, all we do during the initial period of life may change the perspectives of the development of in many ways. Can improve connections with the babies, with their family, feeding, general health, cerebral development, and comfort. The baby must be comfortable to develop well, to connect to the environment and the family, to accept the food and enjoy it. So let's hear a little bit, Dr. Arvedson. Welcome.
It is a real privilege and pleasure to share with you for these few minutes on a topic that is very important to both of us and to many, many people who will be involved with your conference, as well as colleagues who are working with babies and children with feeding and swallowing problems. I will just start with a few general comments, and then I know you have questions, and we'll just take this back and forth for a few minutes here. The most important aspect, well, maybe two important aspects. Infants have to have a stable airway in order to feed by mouth. We talk about infants being obligate nose breathers, meaning any kind of nipple in the mouth, whether it's from a breast or a bottle, they have to be able to breathe easily through their nose. So that's something that every one of you observe when you first look at an infant. Your assessment begins before you ever get close to the mouth. So a stable airway, and they also must have their nutrition needs met. I don't make recommendations about nutrition, and likely most of you don't either, but we always have to be aware of that. I'm also going to remind us that when we talk about neonates, that is a definition for the first 28 days of life. And sometimes people talk about neonates when they're 6 months old. That's not accurate. So then they are infants. But when we think about the feeding, we have to think about both sensory and motor aspects. And that means not just at the mouth, it means what happens about the whole body. And when we think about oral feeding, we have to look at acceptance without stress as a fundamental principle that underlines all of oral feeding. No infant should have a nipple pushed into their mouth or anything else when they are not calm and awake, Some of them may even have their eyes closed, but when they are calm, they are awake. And probably, since we're talking more about feeding, you may be looking at these infants as it's close to a feeding time, whether they're being fed by an OG tube, an NG tube, or a tube directly into the stomach. Remember, those feeding tubes are tools that aid in the nutrition, and it is not a sign of failure when a baby has to have some supplement by a feeding tube, even if the feeding tube is needed for several months or even years down the road. So that's an important concept too, because often parents will say, but I want my baby to eat by mouth. I don't want a tube. That's a failure. Well, we have to help those folks realize that the most important thing is pleasurable, non-stressful feeding that is safe. That means not at risk for aspiration or getting pulmonary problems, and that it is typically done in short time periods. And I will add right now, even though we haven't really gotten to this yet, that you stop the feeding process when you think the infant would still do a little bit more, because even very young preterm infants, very young infants who may have multiple medical and surgical diagnoses, I do believe, and there's some literature to support this, not a lot, that babies remember how things end. And if you can end on a positive note and developmentally and all those other things they're ready to do another session the next time or in the near future, then that baby has that positive memory. We don't know how to measure memory in babies, but think about that. Those are very important fundamental concepts. And I'm sure there are lots more, but maybe we're better to keep going here with Cláudia asking some questions or making some comments as well.
This is Joan. She already answered everything. Yes, I agree with everything you already talked to us. This is fundamental.
So let's move to incorporating the primary caregivers, the mothers, the fathers, and some of these terminology aspects are actually changing too. But if I use the word mother as the person who's the primary feeder, it could be any number of people. Clearly, if it's direct breastfeeding, it's going to be the mother. But what do we need to do before we even get to the mouth, especially for very preterm infants? That's allowing them to get the smell, the feel of the primary caregivers. And that's what we call skin to skin. It is still in some of the literature talked about kangaroo care. That was a term that was used for a long time. That terminology is changing. And I find that when we talk about skin to skin, that really says what is happening. So the better we can use terms that are concrete and clear to our parents as well. What do we mean, kangaroo? It's skin to skin. And that means not only with the mother, it may be with the father, or it could be with a volunteer who comes into the unit and holds babies, feeds babies. And I'm sure there are many variables in the units that you have in your hospitals in Brazil, just like there are variables in the United States. What would we want as the ideal for family involvement with these very young infants? Wouldn't we like to have the mother, the parents be there all the time as though they were at home, but with added nursing and therapy help as well? That would be ideal. It's not practical in a whole lot of places. Number one, there might not be enough room, space. And number two, well, parents might have another child. They might have a job that they need to keep in order to keep their family together. So that's not going to be practical for everyone. But what we would like to have happening is that our units are set up so that the family, the primary caregivers, I'll use that term, can be with that baby as much as possible, and particularly involved with the feeding as much as possible. As a therapist, I shouldn't be a primary feeder. Even nurses shouldn't be primary feeders, although in many situations they do, and that's a positive thing as well. But what can we do to help to facilitate all of the closeness of the caregiver and the infant to help the development in all of the sensory and motor aspects as much as possible? So I think sometimes we put too much emphasis on what happens with the mouth, but positioning, stability, all of those kinds of things are necessary in order for us to get at the mouth in any meaningful and non-stressful way.
Well, you talked a lot of things that are very, very, very important, but let's think about one topic now. I think speech pathologists working with babies during this initial period many times are focused on strategies for working with the oral, motor, and swallowing function. But these babies' needs and families also needs another type of strategies that what you were talking to us now, okay? So tell me about a little bit about your experience with families during this neonatal period of the first months of life, because I think the strategies, speech pathologist strategies are very important. But the results and the success of our therapy, it's not only exactly the technicians or the techniques we use, but the whole thing. And also how we communicate, how we work with the family and the baby. Tell me a little bit about this experience you have in the United States. And if you agree with me that the results are not only vinculated with our practice, specific practice.
Right. The focuses that speech pathologists have are just a very small segment of the total aspect about feeding, nutrition, growth, and development. And when I walk into a room, or I actually see even more just post-NICU, sometimes 10 days old, a week or two after they've left the NICU, so these same principles apply. I will ask the parent to take the baby and just hold that baby. And then I will say, even though your baby is only a few days old or a few weeks old, you know your baby better than anybody else does. So we will look together at some ways that we may be able to help what is working to work even better. This is not a matter of something being good or bad, or right or wrong. And babies change very quickly, almost from day to day or week to week. So as you get to know your baby and your baby gets to know you, you figure out what the positioning may be that is even more useful. But fundamentally, you do keep that baby so that the back or the trunk and the neck and the head are in a neutral straight line. Whether you are putting that baby in side lying for feeding or a semi-upright position for feeding, we do not want the neck to be down, no chin tuck for a young infant because the cartilages in the neck, in the pharynx, are fairly soft. And that means the baby could collapse the airway, not permanently, but collapse the airway. We also don't want them to be tilted back because then liquid may dump too fast into their pharynx and their timing gets thrown off to suck, swallow, and breathe. Now, when a baby is at the breast, that baby is probably going to be tummy to tummy and that little bit different, but that alignment is still critical. So how do we help the baby to continue to breathe easily and be in the alignment? And then another basic concept that I always think about is non-nutritive sucking. That could be on, do you call it pacifier or dummy? The kind of nipple that they use for non-nutritive sucking.
We also use
little finger. Yes. So non-nutritive sucking without having to coordinate suck, swallow, and breathe, I describe as a necessary but not sufficient skill for oral feeding. So that's really what you test. First of all, with a finger or the pacifier to the lower lip, the middle of the lower lip, and not wiggle and jiggle side to side. That's aversive. And you watch to see, does the infant begin to use the tongue? And as the tongue goes into kind of a sucking motion, then you can ease the finger or the pacifier into the mouth as the infant pulls it in. You don't push it in. You let the infant take the lead. And in fact, in these very early days, it is the infant who needs to take the lead. And that's why we talk about the experiences have to be baby-led and behavior-based so that we can promote those biologically expected experiences, whether it's bottle feeding, breastfeeding, or even tube feeding, and there may be sucking on a pacifier. They should all be able to have the opportunity to suck. And some of them, if they have been intubated, any kind of a tube, they're sucking on their tube well before they're even at an age where they could begin to do oral feeding. So that placement and that ease is a very important underlying principle. Total feedings, if they're taking everything, should only be about 20 minutes. Or with a very young infant that you are just beginning to give them the experience, we urge about 5 to no more than 10 minutes. Maybe it's 15 ml, maybe it's only 10 or a little bit more. The volume is not important because you're not trying to get them to meet all of their nutrition needs in these very early days. But you want to give them pleasurable, developmentally appropriate experience. And if you can do that, the infant wakes and is calm, do that multiple times per day, not just once a day. Here's a fundamental principle for all of us. We learn skills better by frequent and short practice times. So you don't want somebody feeding all day, but if they feed for 5 to no more than 10 minutes, and then the rest of the feed is given by the tube, whatever that is, and then at the next feeding, infant's calm, awake, and gets another short practice time that is pleasurable, not stressful. Those are the key things. Not stressful, pleasurable, baby-led, and watch their cues and help the family to have the confidence to know that indeed they are the best people to be feeding the baby.
Yeah.
As a therapist, I don't need to be the one feeding the baby even once a day, but we do need to go in regularly and help to make changes, help the parent to have that confidence and support the parent.
Yeah.
And sometimes it's training nurses or facilitating the nurses. And all of those things that then will really work together. But the family is key. And that's probably one of our most basic principles as we work with our international group to alter and change the whole NICU environment in terms of pain and pleasure and skin to skin and lighting and noise and the family being involved. So we really make those as the primary goals. And it all has to fit together.
And giving support to the family. And I think also the whole team has to develop the same view about the baby, about the care, to promote better development. It is not easy. I don't think it's easy for everybody to have the same view. We have to keep on studying and education of the team, so then we can do a better thing for the babies and mothers. But in Brazil, I think it's the most difficult thing to have the whole team together working for the best development and paying attention with the baby's cues or taking care of the family, because many times we feel a lot of pressure in Brazil, a lot of pressure for the discharge of the babies, a lot of pressure, and this is not good, because the baby could go home without having a good feeding activity process, the discharge.
And the last thing we want to happen is that they fail after they get home. So if there's too much pressure on getting them to increase the volume, get enough by mouth that they go home, but they really can't do that every single day, every single feed.
Yes.
And then they don't gain weight. And then we have this term in English, failure to thrive, which I think should be thrown out.
Yeah.
Because what does it do? It makes parents feel like failures because their infant can't thrive. It is better to use the term, and I don't know how it would translate, but you know how it would translate, to say undernutrition or slow weight gain. Let's just tell it in a way that is more descriptive. Failure to thrive isn't even really a descriptive term when you really think about it. So slow may be likely to become faster in the long run. And that's not an easy concept for parents to accept. And I'm surprised at how many families from different cultures and different languages, and you have multiple cultures and languages in Brazil. I know that. And we have to always be thinking about that too. So the babies tell us what they can handle. They don't always tell us in ways that we easily understand. That's why we always have to keep watching, listening, and asking what else might be going on. What else do I need to think about? What else could we try? There may be something different as well. So I have two favorite four-letter words. I say in English because they might not be four-letter words in other languages. And then in English, we often talk about four-letter words being naughty words. But we have some very important words that are 4 letters in English: hope, love, care. So always keep asking, what else? For every one of you, whatever setting you are in, whatever types of babies or children you are working with the families, what else do I need to think about? What other information might we need? Maybe a baby needs an upper GI. Maybe a baby needs a swallow study. We don't want to do studies if they're not needed. But with the whole team, just as you stressed earlier, Claudia,
Yes.
the doctors, the nurses, the dietitian, the therapists, the social worker maybe,
Yes.
all working with the family, with the parents, the baby being at the head of the team, always. And maybe that's enough for now, Claudia?
Yeah, you asked everything. I didn't even answer. I didn't even ask, and you answered everything. But it's perfect. It's very nice to hear everything and always learning, because it's exactly like this. We have to take care with these babies slowly and pay attention, talking to the team and supporting the family for them to be confident with their babies, because they are going back home with their babies. Yeah. So, but I think, Joan, that this period during the hospitalization, it's very nice for a lot of families, because many times they go home confident. And when we work with term babies that go quickly to their houses, I see that families don't know what to do. They don't know what to do with the babies. And the babies, they are very, very small, that suffered, had pain, and a lot of things during the hospitalization, many times go better to their homes. And in Brazil also,
Yes.
we have a lot of babies that achieve breastfeeding. And many mothers from term babies ask me, how can it happen? Because they are very, very tiny and achieve breastfeeding. Because I think the support is very important. And getting confident about their babies. This is the first step. And many times the speech
And we know
pathologist,
that breast milk is the very best nutrition for them.
yes,
So we encourage the direct breastfeeding, and for some, they have to do some pumping to be able to give the expressed breast milk too. That's kind of a whole nother topic, but that's also a very important part of what we, a speech pathologist, isn't going to do all of that. But again, it's a team.
yes,
Can't do it without a team.
exactly. For them to go home and then continue the development very well with their family. And it's not only the mouth, because I think we develop a lot in speech pathology. So you have a lot of fields, the swallowing, the feeding, but how can we work with babies? We have to put everything and more, because we have to learn how to communicate with the team, how to communicate with the family, because the family is going to take care with the baby, exactly what you already told us. So I think you answered me everything, because I was very anxious to hear you talking about manipulation, discomfort, stress, and I think you explained everything. And everybody, I think it's very important, everything you explained to us. And we may have different cultures and different formation studies, but we have to develop this ability to learn what the baby is showing us.
Yeah.
And I think this is the first thing. And for the family too, because
Yeah.
family are generally are very anxious about hospitalization. And we have to be the professional who is going to be calm, stop, talk, and look at the baby together with the family. Perfect.
And make
Joan.
things as functional
Function.
in non-stressful, I'll say that again, ways, always saying, what is this baby telling us? What is she communicating to us that she can handle or not manage at this time? And I will tell you, for most of us, probably all of us as speech pathologists, we do not get this kind of training in our bachelor or master's programs, whatever your system is. There's so many areas, as you just mentioned,
Yeah.
that we cover. So this becomes a very specialized and the highest risk area that speech pathologists can be practicing in, because we always think that we can't hurt our children if we don't help them talk as clear or as young or whatever. But we can harm babies and children about feeding kinds of things. So it is a high risk area, and we do not do it alone. As we've stressed the team, and you will continue to stress the team, but we also bring a very important role in all of these because of the kinds of knowledge and experience we bring to it, and that we keep learning over a lifetime. I maintain I have more questions than answers. And some of my younger colleagues say, well, don't say you don't have any answers at all, because you do. But we have more questions. And it's asking questions that help to keep us becoming even more helpful to those babies and families. So I just encourage all of you in all of these ways, every little bit of positive differences you can make are so important. And it is one step at a time. And I just feel privileged that you're taking time to listen to us have this little chat. Claudia, thank you.
Oh, perfect. Thank you so much for your time and for all the experience and knowledge you share with us today. Very, very nice. Very happy to see you again. And I'm sure this interview is going to help a lot of people to focus directly on the signs of the baby and one step at a time. Perfect, Joan. Perfect. Thank you very much.
And I look forward to another time.